So thank you very much, Chairperson, sirs, ladies and gentlemen. I was told it will be 10 minutes plus 5 minutes of discussion, so I'll try to stick to that. So I've been asked to speak on liver transplant for HCC beyond UCSF criteria, and of course this would come under the controversies and challenges heading of this conference. What I tried to address today is I tried to go into and tell you how we are managing patients today with HCC in an era of transplant oncology. This is how we are thinking of patients today. And in this, there are two aspects that I still would like to stress on. One is to still say that what is old is gold. And second, to look at what is new and what has evolved over a period of time. Now, what I think still remains, or old is still gold, is that the only curative treatment for HCC beyond very early stage or some early stage tumors which can be managed by the intervention radiologist is surgery. And that surgery can either be resection or liver transplantation. And therefore, when you look at a patient with HCC, the goal should define your means. So you're looking at a curative treatment and you're looking at an intention to treat sort of curative treatment to take them to surgery. The second aspect is that liver transplant is usually the best option in patients with HCC. Why is that? It's because when you have a cancer, the only thing that you're looking for is an R0 resection. And in HCC, more often than not, you're going to have multicentric disease. So although you believe before transplant that these may be within UCSF patients, on pathology, there are actually many more who are beyond UCSF. And therefore, if you want to get an oncologically curative surgery in these patients, the only option probably is a transplant. So if you look at before 2022, this is the BCLC staging system that we were using for more than 2 decades. Transplant and resection were completely out of this beyond UCSF patients. That means intermediate stage and advanced stage. And we were looking at only palliative treatment in terms of TACE and sorafenib with a 3-year survival of 10 to 40% in these patients. However, you look at the 2022 update, and this is for the first time that transplant comes into the domain for intermediate stage HCC. And why has that come and how has that evolved? We all know these criteria, the Milan and UCSF criteria, and we have all been following it, and we know they are the best criteria. However, there have been multiple series, both in the DDLT as well as in the LDLT setting, where these criteria have been expanded. And when you expand these criteria, they were found to give outcomes which are comparable to Milan. Especially in the Asian countries where DDLT is not very frequent, it was the LDLT centers that expanded these criteria, and the main impetus now was on no extrahepatic disease, no gross vascular invasion, and not so much on number and size. And what was important was the use of tumor markers to tell you about tumor biology. And therefore, mantra number 3 is we now know that tumor biology is the key. And it's not just size and numbers, and you'll see that in all the criteria across the world, this is what has been incorporated. And that's where BCLC 2022 tells you that you can actually go to extended liver criteria, transplant criteria, and what you use primarily there is the size and the alpha fetoprotein, or tumor biology in other words. There is another aspect in BCLC 2022, and that is about stage migration. What does that tell you? It tells you that if you have a tumor which is beyond your criteria, and you are able to successfully downstage these tumors, you can actually get them into your transplant criteria and go ahead and transplant them. So this is the UNOS protocol now. It was initially the UCSF downstaging protocol. This is now incorporated by the whole of UNOS. And if you are able to downstage these patients and get them into your acceptable criteria, you can get a 5-year survival of more than 70% in these patients. This UNOS downstaging criteria has now been even further expanded, and this is what is called as the all-comers criteria. This is through what is known as the Merit LT Consortium, and this was published in 2025, August, in hepatology. And you will see in this group also, if you have a patient who is beyond all criteria, that means he's got large number of tumors with large sizes, and he even has portal vein tumor thrombosis, and you were able to downstage these patients, about 63% of these patients were downstage, and you look at the 5-year survival, overall survival, as well as the recurrence-free survival in these patients, it is considerably high if you were to downstage these patients. So that means any patient, if you are able to successfully downstage and bring him into criteria, then you can get good results in these patients. And the salient points of this publication that has just come out in hepatology is that in these patients, probably TARE is better as compared to TACE. Number 2, if the all-comers can actually be brought down by downstaging into acceptable criteria, you get an overall survival of more than 70%. And who are the best people for these all-comer criteria? It is patients who have a sum of tumor number and largest tumor diameter less than 12. You exclude those patients who have an alpha-fetoprotein of more than 100, and exclude those patients who are Child's B and C. So in all comers, if you have a Child's A patient with a low alpha-fetoprotein and sum of tumor number and largest diameter less than 12, if you are able to downstage them, you are going to get very good long-term results. And it is this concept that we have imbibed for many years now, and we published this in 2021, where we were actually able to divide patients with HCC based on a competing risk regression model into low risk, moderate risk, and high risk. And these patients had a recurrence of 9%, 25%, and 46%, and this was based upon 3: alpha-fetoprotein, UCSF, and FDG18 PET. And this is the algorithm that we now follow. Based on AFP, UCSF, and FDG18 PET, if you have a low-risk individual, that means he has no risk factors, or he has only one of the risk factors, then you go for upfront living donor liver transplant. If you have a moderate risk individual, that means you have 2 risk factors which are present, you would downstage them if feasible. And in this, we prefer more and more TARE as compared to TACE. If he's high risk, no way you can transplant this patient. You need to downstage him, bring him into the low risk category, and only then go ahead and transplant these patients. We have also used immune checkpoint inhibitors. I cannot finish my talk today without talking about immune checkpoint, because these are the new kids on the block. And in fact, there have been series now where you have used immune checkpoint inhibitors for all comers to bring them into criteria and then transplant them. And this is something we incorporated in these ILTS guidelines, the consensus guidelines that we published in 2020, where we said that now we are moving towards a composite criteria of tumor biology and response to neoadjuvant treatment, and not just UCSF criteria or size and number criteria. We also said that the selection criteria can be slightly different in LDLT as compared to DDLT, but you should have an overall survival of more than 60% at 5 years if you're thinking of expanding your criteria. In INASL, we've been a part of this, many of us in the audience here, and INASL also now has incorporated this, where we have divided this is the Puri 3 recommendations which we recently published, intermediate stage divided into B1, B2, B3, and B1 are those extended LT criteria patients who can be downstaged and taken up for transplantation. So mantra number 4 is that stage migration is an actual possibility with downstaging therapy, and if you downstage patients and transplant them, you're going to get excellent long-term outcomes. Let's come to the advanced stage. And if you look even at the BCLC's update of 2022, this advanced stage will include both patients who have portal vein thrombosis, tumor thrombosis, and also patients who have extrahepatic disease, and they are clubbed under one single heading of advanced stage disease. Now we all know that 10 to 40% of patients with HCC will present to you with a portal vein tumor thrombosis. And as I said, both of them, whether they have portal vein tumor thrombosis without any extrahepatic disease or they have a combination of both, are clubbed under one heading. Everyone talks about giving them systemic therapy, and they talk about more than 2 years survival, and we all know that this is untrue. The median overall survival in these patients remains very poor, 5 to 19 months, and the time to tumor progression is only around 4.1 months. So the first aspect I think we need to look at is that you cannot club together patients who have only portal vein tumor thrombosis without systemic disease along with patients who have systemic disease. I would prefer to call them as locally advanced hepatocellular carcinoma if they have only portal vein tumor thrombus and they do not have extrahepatic disease. So that's what we did in INASR also. We classified stage C into C1 and C2. C1 is portal vein invasion without any extrahepatic spread, whereas C2 is if you have extrahepatic spread. And in C1 we said that you can do things beyond systemic therapy alone. So if I look only at this population, locally advanced HCC with portal vein tumor thrombosis, this is something again we published in 2022. At that point of time we had only 25 patients with portal vein tumor thrombosis whom we had downstaged using a combination of TARE and SBRT, and we were able to completely take care of the portal vein tumor thrombus and then transplant them. And we were able to get an overall survival of more than 60% in these patients. This is just an example. This is before SBRT. You will see that there is an FDG18 avid right portal vein tumor thrombus. This is post SBRT and before transplant. Similarly, you have a tumor there on the left side, again completely taken care of with SBRT. And then you have a combination of TARE and SBRT. In fact, this is a patient who has a VP4, a main portal vein tumor thrombus. This patient we treated with a combination of TARE and SBRT. We waited for a period of about 1 year in this patient post downstaging. He was transplanted in 2017. We are in 2025 today, and he is alive and disease-free at present. So this is how TARE and SBRT could completely take care of the portal vein tumor thrombus, and then we went ahead and transplanted him. This is updated, but this is updated March 2024. We had 66 patients at that point of time, downstaged using TARE or TACE with or without SBRT. A mean follow-up of 36 months in these patients after downstaging. And you will see there overall survival of 57% at 5 years. 61% recurrence-free survival at 5 years. We had 15 long-term survivors, more than 3 years, and 7 of them were surviving more than 5 years after transplant post-downstaging with portal vein tumor thrombosis. We had 9 recurrences, which was about 20%. 17 of them died, 5 post-op, 4 due to recurrence, and 63% of patients were alive without recurrence at last follow-up. So if you compare a 3-year survival of 10% versus a 5-year survival of 57%, you will see how much transplant benefit these patients had if they were downstaged and they had a transplant. And we were probably the ones who started off, but now you have several series that have published this. And again, I've put it for want of time. I'm not going to go into details of this series, but this is there in a recent review that we published in the Journal of Hepatobiliary Pancreatic Surgery. There are some caveats though. You start with 100 patients with portal vein tumor thrombosis and you try to downstage them and take them to a transplant, you will be able to do it only in 50. So there's a 50% success rate that you will actually be able to take them to transplant. Number 2, your liver function does determine whether you're able to give these downstaging therapies. So you need a good CTPA patient with good amount of non-tumoral volume if you want to give this particular treatment. The third aspect is you have to adequately wait after downstaging to make sure that the chances of recurrence are low. And how effectively you deliver the downstaging therapy is what matters. It needs to be done by an expert intervention radiologist and radiation oncologist, and only then you will actually get the effectiveness. Another point that I have not put there is if you have hepatic vein tumor thrombus, along with the portal vein tumor thrombus, it's a completely different ballgame. Having hepatic vein tumor thrombosis is a bad prognostic factor and you will have a bad outcome with high recurrences. Again, immunotherapy has been used to downstage these patients, and we have now transplanted 6 patients post combination of immunotherapy and TARE or SBRT and had good outcomes in these patients as well. Again, for want of time, I'm not going to go into details of this, but these are all recent publications that we made on this particular aspect, and those interested can go and read these publications. The last 2 slides that I have are talking about transplant benefit, the concept of transplant benefit in locally advanced HCC. And in simple terms, transplant benefit is the gain offered by transplant in comparison to best alternative therapy. That is survival after LT minus survival with best alternative therapy. So if we were to employ that in our own population, we found that in the low risk group, just at 3 years, we had a 27-month transplant benefit. At 60 months, that is at 5 years, we had a 42-month transplant benefit. And even in high-risk group, we had a 25-month benefit of transplant in patients who had multinodular HCC beyond UCSF criteria. And for HCC with portal vein tumor thrombosis, we had a 23-month transplant benefit that means 2-year transplant benefit even at 3 years. So if you look at this, actually the highest survival benefit in patients with HCC is actually in those patients who have advanced HCC as compared to the early HCC. There is a cost of expanding the criteria. Recurrence rate is going to be slightly higher, about 10 to 15% higher, but you are going to give them a huge benefit as compared to just palliative therapy with a TACE. So to conclude, ladies and gentlemen, I think that in a day and age of transplant oncology, we cannot make rules for every single patient. There cannot be one rule for every patient. We have to sit together, all of us who are involved in the care of those patients, in a tumor board, decide what is best for that particular individual and take a decision based on that. Thank you very much for your patient listening.
Thanks, Prashant. Good, nice talk. Just wanted to know, most of your patients with portal vein tumor thrombus, they were VP2 and VP3. Only 3 patients had VP4. So what was the outcome in those patients, and what would you recommend for these kind of patients? Like we should routinely do SBRT and TARE and take up these patients, and what are your criteria?
So thanks for that question. So I think that the proportion of VP2, VP3 and VP4 itself tell you that these patients are very difficult to downstage and actually take to a transplant. So the chances of downstaging these patients with VP4 tumor thrombus are much lower as compared to those where you have VP2 or VP3. As I said, in that one patient whom we had transplanted, in most of our VP4 patients, the waiting period has been almost 6 months to 1 year after actually downstaging these patients, because you need to look how the natural biology of the tumor is progressing. So that waiting period is absolutely essential. But after a prolonged waiting period post downstaging, if you find that the tumor thrombus is inactive on FDG18 PET as well as on a triphasic CT, you have tumor markers which have come down and you have a very good delta AFP. That means the first AFP versus the last AFP. And you have had a good waiting period. I think they deserve a transplant. But the chances are lower that you will be able to downstage them and maintain them there. But in those selected few patients with a good tumor biology, you should transplant them. In all these cases of VP3 and VP4, now we again follow a rule that in order to make sure that you are going beyond, that means proximal to the portal vein tumor thrombus, most of these patients we would put in an extension graft from the SMV-SV confluence as a surgical procedure to make sure that you're taking a good margin beyond this particular tumor thrombus before you actually transplant these patients.
Right. And you said you have done about 6 patients after immunotherapy.
Yes.
Right. So you use CTLA4 antagonist along with PD-L1 inhibitors, or you just use PD-L1 inhibitors, atezolizumab with basis?
So we've used in these patients a combination of local ablative therapy along with systemic therapy. So in all these patients, the use of systemic therapy has been primarily atezobev, and the local therapy has been either a combination of TARE SBRT, or it has been TARE alone, or it has been TACE. Again, the important point in these patients is these patients have been on therapy for 2 years and have shown evidence that there is no extrahepatic disease and there is no progression of disease. So they've had stable disease or downstage disease, and only then we have transplanted them with a very prolonged waiting period. So I would say probably maybe around 100 patients have received immunotherapy. I think the last time that our hepatologist looked at it with HCC, but out of that we've transplanted only 6. So that means we've really selectively chosen, we've been very, very selective in choosing these patients.
So out of these 6 patients, any of them had TARE also, or only TACE or SBRT?
Did they have, sorry?
TARE procedure along
Yes, yes, I said TARE or TARE plus SBRT, or they had TACE plus SBRT along with immunotherapy.
Thank you.
Hi Prashant, nice talk. Regarding hepatic vein thrombus, how is your approach different in this patient? Do you still, with portal vein tumor thrombosis, how is it different because it's a systemic disease, it's more of a systemic once hepatic veins is there.
Yeah, so I said that again, that one of the caveats is presence of venous thrombosis, hepatic vein tumor thrombus, and I think these are completely different patients. Patients with portal vein tumor thrombus are different from those who have both. Hepatic vein tumor thrombus is closer to systemic disease as compared to portal vein tumor thrombus, I feel. And those have been our results. So initially we did transplant some with very good response to the HVTT as well. But then many of them had very early recurrence. So now we are very selective. I think over the last 2.5, 3 years, we've transplanted probably 2 patients who had hepatic vein tumor thrombus in the right hepatic vein. Again, completely taken care of with TARE SBRT, downward tumor markers, had very stable or downstage disease, waited for around 6 months, and after that we've transplanted. But we are very, very careful about transplanting patients with HVTT. I don't think they are the same group of patients. They are very different.
What is the waiting time for these portal vein thrombus patients after this neoadjuvant therapy?
So I think, again, it depends upon your level and grade of thrombosis, VP1, VP2, VP3, VP4. VP1, VP2 would be more of segmental portal vein tumor thrombus. So in these patients, we waited for a period of about 6 weeks after the complete downstaging therapy has been done. In VP3, we have waited for at least a period of 3 months, because once you've given the therapy, you've done scans at 6 or 8 weeks and then again at around 12 weeks, and then you have decided whether you can go ahead with transplanting these patients if it is completely naive. At the same time, in VP3, we have had instances where if there is a residual portal vein tumor thrombus, we have again done SBRT to completely take care of that tumor thrombus. So there has been repeated radiotherapy being done to make sure that there is completely non-arterial enhancing and FDG non-avid tumor thrombus before progressing. So the waiting period has been minimum of 3 months from the time of initiation of the downstaging therapy.
Any more
Thank you,
questions?
Prashant. I think you just once again shown why you are the go-to man for HCC. I just have if the patient is stable, yeah, we can put them through all these local therapies and therapies. So the problem, the most tricky problem we have is a patient who's got child C cirrhosis, who is not ready for any, who is not fit for any local therapy, and they have this tumor, maybe VP1, VP2. So what is how do you go about managing pain? Because if you're talking about transplant benefit, definitely they'll be benefited by transplantation over, palliative care.
Yep.
But how do you do that in your unit?
So, in the very early days, I think in 2014 or 15, I presented a paper from our group where we had transplanted patients with VP1 and VP2 tumor thrombus. We had 13 patients like that whom we had transplanted without any sort of therapy. Why did we transplant them? Because they were so sick, exactly the scenario that you are telling us. Patient would have died of liver failure, and there was no other option for those patients to save those patients. So we transplanted them, went ahead and transplanted them. Interestingly, we found a 3-year survival of 57% in them, overall survival of 57% without doing any sort of therapy. So I think I also put it in that algorithm of mine that if feasible, you can downstage patients with moderate risk. Why is it not feasible in them? Those patients who have more than 3 bilirubin, those who have child C cirrhosis, who cannot undergo either a TACE or an SBRT or TARE. So the risk of recurrence there is 25% in our study. So I think if you are pushed to the line there are other things that you have to employ when you're doing this particular thing. Number one, first of all, you would, during your surgery, employ techniques that have been shown by groups like ASAN to be useful. For example, completely divide the porta first, don't mobilize the liver, and mobilize the liver only after complete division of the porta, and they have shown very significant benefit in recurrence in this, if this particular thing is done. So porta division first, before mobilization. The second thing is post-operative period. So in the post-operative period, very early switch to mTOR inhibitors with reduced tacrolimus. I think that is very important. Don't give them too much immunosuppression. Number 3 comes the role of prophylactic use of, say, lenvatinib. And I think till today, there is no literature or there is no published study, and I don't think they're going to have it in the future also, which tells you that you should prophylactically use lenvatinib in these patients post-operatively. What you can do is you can do increased surveillance and catch the recurrence early. So instead of doing a 6-monthly CT scan in these patients, we do a 3-monthly CT scan, which may be either a PET or it may be a CT triphasic, along with tumor markers. and catch it early, because in our another paper we have shown in 100 recurrences, if you were to catch these patients early and treat them with a multimodality treatment, you can get longer survivals in them also. So I think when you are completely lost at options, these are the things that you can follow in these patients. Yes, I would consider transplant if they are going to die of liver failure and they have a tumor which is with a VP1, VP2. I would consider VP3, VP4 completely differently. VP3, VP4, I think we would not do it.
Hey, can I make a quick comment?
Yeah, Abhishek.
Hey, how are you?
Hi.
Abhishek Mathur, just to sort of preface my comment, my context comes from working in the US for the last 8 years. But I think your last point is really important about, which goes into defining success. As you mentioned, like your recurrence is going to be slightly higher, your survival is going to be slightly lower. And defining success is important for, for the institution and for the, the entire community. Because part of the challenge in the US is you're competing against for deceased donor organs as opposed to LDs. So you've got to have success and recurrence rates that result in appropriate utilization. But sorry. But I think this is really important because you have to talk about this more so that we can redefine success as a community so this is more normalized everywhere, even where DDLT is more common.
Sure. Thank you.
Just one last question. What was your average cooling off period in these 6 patients after stopping immunotherapy and transplant? And
So
any severe rejection you had?
Yeah. So I think we did a ILTS consensus conference last year in Valencia, where we looked at this, because now immunotherapy is going to be used more and more. So it is now proven, and there are recent studies now, that you have to wait for 2 half-lives after the immunotherapy has been completed before you actually go for transplant. So 2 half-lives would translate into around 6 weeks. So I would say you have to wait for a period of 2 months before you actually go ahead with the transplant. So that's what we have followed, and there is very good data now to show that 2 half-lives of the drug is what you have to wait for, and generally it comes down to around 45 to 60 days. So 2 months waiting after the immunotherapy is completed, last dose of Atezobev.
No severe rejection post-op?
No, we've not had severe rejection at all. I think most of the studies that were published were with nivolumab mainly, and with Atezobev, with that cooling period and waiting period that we are talking about, the rejection or the the graft necrosis that was all defined in the UR, we've not had that.
Thanks, Prashant.